of interest to everybody, whether he is a neurosurgeon or pulmonologist or gynecologist, whosoever. Everybody has to see a patient of hypertension. This is the start of cardiology, the first ECG machine. Just imagine a big room and a big gadget, and the recording was very lousy. But this is how things start. That was the first ECG machine. And now you can see beautiful things and very miniature-sized ECG machines, even which can be coupled with your PC. And also the visual science, which is echocardiography. We can see in real time the movement of all the chambers of the heart and valves. So we have traveled on a diagnostic side. This is CT angiogram. Beautiful pictures of coronaries, non-invasively, without putting any catheters or puncturing the artery. Considering all those advances, we are still lacking behind in the understanding of many diseases. Hypertension, we used to think, is a minor degree of rise in systolic or diastolic, which still many people believe. And he is the person who invented or who described Korotkov sounds, Mr. Korotkov. And at that time, he did not realize that this description of sounds will be so important in the near future or in the forthcoming centuries. But soon after, it was realized that whatever the age is, if you have got high systolic or high diastolic pressure, your expected mortality is high. And that was published in year 1939. So everybody was convinced that yes, high systolic or high diastolic is a bad news. But look at it, the genius of that time, Mr. Paul Wood, he wrote in 1931 that the biggest danger in high blood pressure lies in its discovery, because then some fool will try and reduce it. Because in those days, he admired the gravity of the problem, but the answer was not simple. Because the treatment which was available was not very safe. That's why he said, treating is more dangerous. But then, obviously, over the years, what we have seen, a steep rise in the incidence and prevalence of hypertension, not only in the developing countries, in the developed countries, but in also affluent countries. And the dilemma does not come in soul. It is associated with so many other organ involvements or risk factors. And whatever we come from, the traditions we come from, there will be rise in the prevalence. This is the data which shows that in the years to come, there will be a steep rise in the incidence and prevalence of hypertension, which is pity. We could not control it. And this is very alarming. Once you cross the line of normotension, you become hypertensive. There is steep rise in the 5-year risk, whatever gender you come from. And even a little rise in systolic or diastolic matters a lot. This is 14-year follow-up published in 2001, and you can see a little rise in systolic or diastolic, whether you belong to male or female gender, brings bad news. And very famous coronary risk chart of Framingham, hypertension, almost in every person who suffers from coronary artery disease. And remains #1 killer, and it will remain #1 killer in the years to come. This is from WHO. It will remain the leading cause of death during at least next 2-3 decades. So we have to work hard and join hands to control it. Pakistan is also suffering from the same. This is which was published in 2010. It was conducted in Karachi. Baloch are the worst hit, maybe lot of stress, and then other ethnic group. Prevalence is almost 20%, and only 20% population is adequately controlled. That is the story of Pakistan. So whatever age, gender we belong to, we have to join hands to control it. Our main problem is how to define it, who is suffering from hypertension. Because patients and public, they think कि जिस दिन सर दर्द होगा उस दिन blood pressure हो जाएगा, जिस दिन गुस्सा बहुत आएगा वो blood pressure का दिन होगा. It is totally asymptomatic disease. So one should not wait for symptoms. Symptoms mean its complication. Then physicians and healthcare providers and industry people, they have got their own motives. But we as physicians always look into the organ damages which will be coming with the development of hypertension. The good news is, whatever the level of hypertension is, once you control it, you can reduce so many complications. With a little fall in mean systolic pressure, 7% reduction in risk of coronary artery disease, and 10% reduction in the risk of stroke. Very, very impressive, with a little change in systolic pressure. We always start with lifestyle modifications, physical activity that is mandatory, not only to normal people but especially to those who are hypertensive. If you are normotensive and you do regular physical activity, you can reduce your systolic and diastolic by these figures, and if you are hypertensive, even more. So the treatment starts with lifestyle modification, physical activity, then obviously diet, then your attitude, and here comes family physician. They know family more than what we know. So they can give an optimistic attitude to all patients. And we have traveled a lot, and there is a long way still to go to understand what is the normal or abnormal systolic or diastolic pressure. These are various JNC from 1 to 7 recommendations. And gradually we have moved up to a lower figures, systolic or diastolic. Because of shortage of time, when it comes to suffering from hypertension, we must always try to find which organ has already been damaged or involved. Whether there are signs of left ventricular hypertrophy, very easy to see on ECG if you don't have echo. And other parameters, especially rise in serum creatinine and microalbuminuria. Mind it, once one patient develops microalbuminuria, he is suffering from coronary artery disease. It is a coronary artery equivalent. And average benefit of lowering blood pressure, stroke incidence we can reduce by almost 40%, infarction by almost quarter, and heart failure, which is more than any malignant disease, by 50%, by simply controlling hypertension. In spite of knowing all these things, globally, the control is very poor. And here comes our medical community. They must help, because this study showed that not controlling adequately means not treating it. क्योंकि जो ट्रीटमेंट ना करने की कॉम्प्लिकेशन है वो अनकंट्रोल्ड हाइपरटेंशन की भी कॉम्प्लिकेशन. So it has to be controlled properly, not half-heartedly. And what are the reasons why we can't get to the goal is patients' compliance. Because it is a lifelong commitment. So patient has to be educated. And then there are other things. And when we think that patient needs pharmacotherapy, there are so many drugs which were invented right from mid-90s to years 2010. So many new compounds, but the compounds which have stayed are these ones: AC inhibitors, ARBs, calcium channel blockers, and beta blockers, and thiazide diuretics. The rest have been vanished because of their higher side effects. And the best today are ARBs. They are the best treatment option because they are very well tolerated, but also on the endothelium. We know by simple giving prescription is not enough. We have to educate the people, and we have to the endothelium, which is most important. And among ARVs, all ARVs are not same. Valsartan is the best ARV. One can call it queen of ARV because it has got the maximum of selectivity as compared to others, which is losartan, irbesartan, candesartan. The best selectivity with valsartan. And valsartan-based therapy, many studies have shown is very effective, prevents complications, reduces oxidative stress, which as a cardiologist for me is the most important thing. And there are huge number of studies in favor of this compound when compared to others, which favor that this is probably the best first option for antihypertensive therapy. And that was the first ARB which was approved by FDA for the treatment of congestive heart failure also. So many studies. So it was proposed that for the treatment of hypertension, ARB should be, or AC inhibitors should be made as a foundation, then add to other drugs. It also reduces microalbuminuria, which means reduction in the incidence of coronary artery disease. And George Curry has also shown it. But dilemma is that with single drug you cannot get an optimal control. And GN7 people said that there has to be combination of 2 or 3 drugs. And if you do fixed dose combination, the compliance improves, which means better control of blood pressure. And there are various combinations which have the best possible combination which suits to everybody. And then there was fixed dose combinations which were launched. Firstly, combination of hydrochlorothiazide and valsartan, and that showed it becomes more effective, giving better control. And then came calcium channel blockers, very effective drugs. And among calcium channel blockers, probably amlodipine was the best, which have been proven by various studies. It reduces coronary artery disease, and it significantly reduces, compared to beta blockers, the incidence and symptoms of ischemic heart. So logically, combination of amlodipine with the best possible ARB could be the best possible combination as a fixed combination. Valsartan, so many clinical trials, amlodipine in parallel, so many clinical trials in favor of it. So there is good rationale to combine them. They have got various favorable effects which favor each other. And if you combine them, you get better response in terms of better control of systolic as well as diastolic pressure. And if you give single pill to the patient rather than multiple pills, compliance improves. And compliance improve means good control of blood pressure. And you can imagine, if you give monotherapy or combination therapy, the compliance improves by almost 90% and control by almost 75%. So Bhs Guidelines came and they were revised, and now they say first drugs which are to be used are either AC inhibitor or ARB, then add calcium channel blockers as a second step. So I'm on my way. Yeah, that's why I'm running fast. Yaar ye ruk gaya. Oh yaar, वो आपने स्टॉप ही कर दिया भाई ये।
उसमें सोफे में जाएंगे।
मुझे पता नैब वाले इधर भी पहुंचे होंगे। So BP lowering efficacy with combination amlodipine and valsartan, very impressive. Superior blood pressure control, all grades of hypertension, diabetes. Another very important issue that any drug which increases the incidence of diabetes is no good. ARBs, AC inhibitors, we all know, they reduce the incidence of new onset diabetes. Similarly, amlodipine, that also reduces the incidence of new onset diabetes compared to atenolol. So that also a good choice, that these lesser edema, ankle edema, which we see with amlodipine, if it is combined with valsartan, there is lesser incidence of ankle edema. So we say drug should be safe as safe is, and they should not oppose each other. They should facilitate each other, but not like this. And it should be economical also. And we should work hard for the education of the patient, because a Chinese proverb says, teach me, I will forget. Show me, I will remember. But involve me, I will understand. So patient has to be involved to understand what disease he is suffering from and what best combinations we offer to him. And this is the hope. Though no one can go back and make a brand new start, anyone can start from now and make a brand new ending. That is for the future. Thank you very much.
Thank you very much, Dr. Ashfaq.